Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. Thanks for joining us. In this programme we take a look at preventative health measures. But before we begin, here's a quick word from Rural Health West's Events Coordinator Lisa Thomas about our upcoming Building the Future conference.
Following on from last year's success in Albany, the Building the Future of Rural Health conference will take place in Busselton this year from the 20th to the 22nd of September. This year the theme is iDocs, Connecting Rural Health Communities. It will focus on ways to connect rural health communities using telehealth. We have a number of engaging keynote speakers who will be presenting at the conference. One is Dr. Michael Zhong from Canada. Michael will be talking about the supervision of student doctors using telehealth resources in remote areas. Also presenting at the conference will be Michael Cadigan. Michael is the founder and editor for the medical blog Life in the Fast Lane and also writes a number of medical education textbooks. Also presenting will be Professor Gavin Andrews from the University of New South Wales and St Vincent's Hospital and Dr Sarah Bird, who's a medico-legal advisory services for MDA National. This year's social events will include a welcome reception at Palmer Wines in Dunsborough, followed by the conference dinner at the Goose in Busselton. The feedback from last year was very positive and we'd love to see you in Busselton in September. Visit our website or give the events team at Rural Health West a call.
Thanks, Lisa. Now let's get into the programme. The links between smoking and cancer are very clear, yet for some people, especially those who've been smoking for a long time, it's not easy to quit. Amanda Siebert from the Cancer Council's Fresh Start programme gave us some tips on how to speak to your patients about smoking and how to help them quit.
Amanda, welcome to the program. We're encouraged to send people to GPs as the first point of contact when looking at smoking cessation. So I just wanted to talk to you about how you see the role of the GP and what we're doing to make sure that GPs have everything that they need to make the most of every opportunity of someone walking through their door.
Yes, certainly. GPs are respected in the community and they have a vital role in working with people who are smokers or even addressing the issue as they come in for their appointment. And like the stats show that 40% of smokers that talk to their GP make a quit attempt, but that's only if the GPs bring it up and discuss it in the first place. And I think that's what we're trying to do here at the Cancer Council, is to get this message across to the GPs, that to bring it up at each session, because it only takes a few minutes. If we follow the 5A model, which is an international evidence-based program, they can address that smoking within the few minutes in the interview process in their 10-minute appointment and get that message across that smoking can harm them. Obviously people know that, but certainly their health issue, for example, if they come in for asthma, their health issue can improve, or they may be spending less on medication if they address their smoking and cut down and quit.
So you just mentioned the 5A model.
Yes.
What are the key points or
the
key parts
5A
of that
model.
model?
Well, there's actually two models. There's the 5A model, which is a bit longer, and then there's the 3A model, which is probably more appropriate for a 10-minute doctor's appointment. So I'll just briefly talk. The 5A model is where you ask the person who comes into a room if they're a smoker, how long they've been smoking and how many a day they smoke, and it's recorded. And then they assess what level of addiction they have, whether they're a low smoker, medium or high, and they assess their level of their willingness to change. For example, someone may be not interested at all, talk to the hand, don't care anything about quitting. Other people may be thinking about quitting, a little bit unsure, and then other people may be going, yeah, well, I actually do want to quit, but I don't know how. So that's assessing, that's the second A. And then the third A is advise. So that's like what I just mentioned. Look, your health issue would greatly improve. It'd be the best thing you could do for your family and your community. And, really sort of highlighting some of the benefits, the money that they would save, or the health improvement, the fitness levels and things like that. So that's the first 3A. So you've got ask, assess and advise. And then the fourth A is assist. So that's where this takes a little bit more time, And this is where you can assist someone to actually quit. So, for example, someone who's not interested in quitting at all, you would just say, look, I'm here and I'm available and I can actually help you when you are ready. But someone who's a little bit unsure and a little bit ambivalent, you can apply what's called motivational interviewing techniques, and that's where you talk about, well, what do you enjoy about smoking at the moment? And, you know, so you start to go through what they enjoy about it, and what are your concerns about smoking? What are the not so good things that you are thinking about when you smoke? And they could be things like, you know, role model for the kids, coughing up, sore lungs, lack of fitness, things like that. So they start to realise that they're actually doing something negative when they're smoking, and they start to listen to their own voice. So that's the beginning of motivational interviewing. And you also discuss the barriers, like what's in the way. Why is it that, you know, you've had a couple of attempts in the past and then, you know, what's stopping you now? And then if someone's ready to quit, well, then you can really start to talk about a quit plan. So that could be, because the best thing to do is to have support, and also you can get prescriptions for Champix, Zyban, or now the patches are on the PBS. So with that sort of NRT support, and then sort of maybe some verbal support or emotional support, you've got a winning combination. So, and then the last A is the fifth A, and that's a range. So if you've prescribed Champix or if you've prescribed anything, you can arrange either a follow-up appointment with yourself, or you can arrange a referral to get that extra support. And the referral process can be the quit line, can be a Fresh Start facilitator in your local area, it can be a psychologist or an addictions counsellor in your local area. Or the best thing you can do, if you're in a bigger practice, is to get one of your practice nurses trained to be a Fresh Start facilitator, which enables that person to work one-on-one with a smoker, or to run a group for your local area. And she can become, or he can become, your practice smoking cessation specialist, and you can refer directly in-house and capture all those smokers and give them support.
And could that practice nurse be trained by the Cancer Council?
Yes, yeah, certainly. We provide a 2-day really comprehensive training, and that enables someone to work one-on-one or in a group setting, and gives them all the skills and tools they need. And also we provide mentorship as well, so if people get a bit lost or stuck with some difficult people, because the reality is a lot of the smokers that come into your practice also have other types of issues as well. It could be other addictions, mental health and other physical problems. So you need that additional support, that additional emotional support and psychological intervention, so that people can start to understand what it is that their smoking is attached to. Because often smoking is a way of self-soothing, a way of coping through difficult situations. And people can be doing it for years and years and years, you know, you have 20, 30, 40 years. And so when difficult situations come up or anxieties come up in their life, they actually don't know how to cope with it other than smoking. So there's strong attachments. It's not just about the nicotine sometimes.
Talk me through the support that is there, that can be provided by the Cancer Council for GPs.
With the GPs, there's we provide brief intervention training. So that's going through the 5A. That's a half-day training, or 3.5 hours. So we can do training for GPs, or we can do training for their practice staff, who are probably better placed to do more of the assisting over the longer term for smokers. And we can also provide facilitator training, which is a 2-day comprehensive training for where some of their staff members may come along to our training, and then they can go back and be the cessation specialist in their area. That's the best way, is to get people trained up in your practice. But if you're a one-off, you know, and you don't have practice staff, or the best thing to do is be whichever regional area you're in, is to either you can use the quit line and organise fax referrals through them, so you can immediately fax through the person's details. Or you can look in your area, because there will be addiction counsellors in your area. There will be psychologists in your area that want to work with smoking cessation and more of the harder cases. And there will be generally Fresh Start facilitators that we have trained in your area. So I think that the GPs have a really good opportunity to make a difference and to highlight the smoking in their community and to bring it up in their consult.
So Amanda, in your experience, what are the key things that will motivate people to stop smoking, and what are the key things in terms of support that you feel do get someone over the edge?
Yeah, through experience, I've been working in this field for a number of years now, and I get to travel a lot and meet a lot of people and talk to a lot of people, plus also our researched evidence around why people quit, what gets them over that line in the first place. And a lot of it is very, very individual, but there are some commonalities, and a lot of them it's about being a better role model. When they become a parent, they suddenly think it's not just about me. And also when they have a health diagnosis, that can prompt. But then sometimes I often see some people have a heart attack and they quit, and then 6 months later they go back to smoking. So that's not always the case. I think it's about 60% of people who have a heart attack stay quit, but 40% return to smoking. And I think another issue is that people start to, as they grow older, their fitness levels go down, and they really start to labour, and they start to think about their own mortality and as they age. And for the younger people, for quitting, it's very much about what they look like and how it affects their facial features and how their skin and hair. So there are some very common denominators. And for Aboriginal communities, it's very much about their community and being a role model and a mentor, and their children as well. Children play a big factor. For example, I was working with a woman and she had a little 3-year-old daughter, and this woman had a very difficult phone call. She was on the phone and she started to cry, and when she got off the phone, her 3-year-old daughter came up and gave her a packet of cigarettes and said, "Here, mummy." And at that moment, it was a light bulb moment for that woman, because she suddenly realised that she's teaching her 3-year-old to smoke when you get upset. And that was the moment that she quit.
And thanks to Amanda Siebert for taking the time to talk with us. Well, next up we spoke to Liz Wylie from Breast Screen WA, and she gave us an update on the Breast Screen programme.
My name's Janet, and I'm the radiographer that we're doing your X-ray today, and I just have a few more questions for you, please. Now, 90% of breast cancers will be detected by mammography. So mammography is extremely effective. 98% of breast cancers will be detected in women who have fatty breasts and very little glandular tissue. In women who have very dense breasts with a lot of glandular tissue, then they're only effective in about 50% of women. The extra glandular tissue makes the mammogram look white, and breast cancers look white, so you end up looking for a white abnormality on a white background. So overall, for all women, about 90% of breast cancers will be detected. There is a less than 30% chance that a breast cancer will have extended to the axillary nodes with a screen-detected breast cancer. So bringing forward the diagnosis to a cancer of a smaller size immediately reduces the chances of local and distant metastatic spread. The program recently underwent a very extensive external evaluation, and that external evaluation was published at the end of 2009. So at that time, that evaluated how successful the program had been from 1991, and in that time, over about 1.5 million women had been screened in the program. They found that the breast cancer reduction in the target age population, 50 to 69, was 28%. So even in that time, the incidence of breast cancer had gone from 1 in 14 Australian women to 1 in 9 women. So the incidence was rising. The mortality had fallen by 28%. And that, I think, the evaluation found that breast cancer screening was quite cost effective, even with a participation rate only of 58%. So at the moment, only 58% of Australian women are actually participating in the program. We actually have a better participation rate for rural women than we do for metropolitan women, and I think that's probably related to opportunity. rural women, particularly in women from remote areas, realise that the van is their opportunity to have a mammogram. So when the van comes into a town, we have a big promotion. We write to all the general practitioners, and we put notices up in the hairdresser and the pharmacy, and we write to all the women we know about from the electoral roll. And women know that we're there for a finite period of time, so they avail themselves of the van before we move on. And I think because the opportunity to have a mammogram is always there for metropolitan women, there's less imperative to have the mammogram, which is probably why we have a poorer participation rate in the metropolitan area. It is a risk of the program that you will be diagnosed with breast cancer when you're going to be run over by a bus in 2 years' time, so you didn't need to know. If we were to do a mammogram today and someone has a breast cancer on the mammogram, but they have a concomitant significant medical condition and they're going to die before the breast cancer had a chance to manifest itself, then clearly that cancer isn't relevant in that woman's life and is over-diagnosis, because we knew that woman has lived with the diagnosis of breast cancer and she was never going to die of breast cancer. But it's very hard to actually communicate that to individual women, because an individual woman doesn't want to die of breast cancer, and she wants that diagnosis of breast cancer as soon as possible to avail herself of the best opportunity of not dying of breast cancer. So every woman who's diagnosed with breast cancer doesn't care whether it's overdiagnosis or not. They want it dealt with as soon as possible. There's the risk of overdiagnosis for a woman, but there is an even more important risk, which is which really does impact on women, and that's false positive diagnosis. Because we know for every 1,000 women we screen, we will detect 6 cancers. But for every 6 cancers, we will recall for every 1,000 women about 40 women. So 40 women will be recalled to the program to have further X-ray tests, to have ultrasounds, to have biopsies and clinical examinations. And those women, until we actually make the diagnosis benign or malignant, all think they have breast cancer, all suffer the same psychological trauma of being recalled, and then and only of that group of women, only 6 of them, so less than a fifth of them, will actually have breast cancer. All of these population programs are about balancing risks and benefits and communicating those risks and benefits to women. The GP's role is pivotal in there, in providing that information for a woman on what screening actually involves, and helping that woman make the decision about whether screening is right for her, and whether and for her balancing the personal advantages with the population risk of overdiagnosis and false positive diagnosis. We know that a woman's life will never be the same after the diagnosis of breast cancer, and that she will be a breast cancer survivor for the rest of her life, and that there are very significant consequences for her family dynamics, for her sense of herself, for her body image. There are significant financial consequences of not being able to work during the time that she's receiving treatment, the cost to the family of actually getting treatment, especially for rural women having to be in a metropolitan area to get radiotherapy. I mean, the consequences for the whole family of the diagnosis of breast cancer are just awesome, and it would be good to know which cancers need as little treatment as possible. How many women will benefit from 1 dose of intraoperative radiotherapy rather than 6 weeks of external beam radiotherapy? Is tailoring screening and tailoring care to the individual woman to reduce the risks and the downsides. The program is a very evidence-based program, that it's a strongly evaluated program, that a lot of resources, several $1 million was put into actually evaluating the cost effectiveness and the general effectiveness of the program. The program has been found to reduce breast cancer mortality by 28% in the population of women over the age of 50, whether they attended or not. So that's just with a participation rate of 58%. There are downsides, but it would appear from very robust evaluations that there are very significant benefits to Australian women, and that we would encourage women to attend for breast cancer screening. 1 in 9 to 1 in 8 Australian women will get breast cancer, and we can reduce breast cancer mortality with early diagnosis.
Dr. Frank Jones is a GP based in Mandurah and chair of the WA faculty of RACGP. He speaks with us about the Redbook and how GPs can think about addressing prevention in every consult as a matter of course.
Frank, welcome to the program.
Thank you very much.
I just want to get your opinion and thoughts on the Redbook and prevention in general practice in general.
Okay, now this is a huge, big topic for general practice. Basically, prevention in general practice is now an inherent part of your consultation. Every consultation you have with a patient involves prevention. So we can talk about guidelines and guidance in just a second, but what I talk to patients about, and indeed my doctors in training, is what I call the golden triangle of general practice. So when you see a patient in a consultation, obviously you're dealing with the presenting problem that they're coming with on that day. The second part of the consultation, of course, is to discuss other ongoing issues that are going on within that patient's life. But the third and very important part of the consultation is prevention. So whenever a patient comes in, there is always a preventative activity going on. So again, I think people can be a bit overwhelmed by all this, and where do you start? So there are some good resources that you can talk about, which I'll mention in a second, which is the RACGP Redbook. But again, I think GPs, because they're so busy, do struggle. Where do I start? Am I doing any prevention or not? Well, again, it's a relatively simple, straightforward procedure. One takes a history, past medical history. One's looking at what drugs the patient's on. We're looking at allergies. Now, taking an allergy history in itself is a preventative activity. You then take a family history. That is a preventative activity. So if your father died at 45 of a heart attack, I'm going to be a lot more interested in discussing prevention with you. So it's actually focusing on your history straight away, what preventative issues are pertinent to that particular patient that are seeing me. And of course, then we're going to talk about the other non-medical stuff, if you like, the smoking, etc., etc. Within the Redbook, which I will mention in just a second, there is a very easy, snappy thing to remember, SNAP. So there's smoking, nutrition, alcohol, and physical activity. So that's a really good thing for, again, GPs to remember in their minds when they're taking that history.
Just as a baseline.
As a baseline. So I think most GPs, if they take an adequate history, always listen to the patient. 80% of the time you'll get an answer to your problem, and most of the time you'll also take that opportunity to prevention because you will have identified that individual's risk factors. Now it gets a bit more complicated as we go down the track, of course, and a couple of years ago when we talked a lot about prevention, Medicare really didn't recognise as a debatable thing to do as a preventive party. It was all about what's happening today. But since 2010, the federal government does accept that we do prevention as part of our jobs, one of our core issues. So when one talks about prevention, there's primary prevention, secondary prevention, and tertiary prevention. What that basically means, the primary is prevention of the initial illness, for example, immunisation, is a primary prevention. There's secondary prevention, which is the early detection of diseases, for example, identifying a person at risk, a smoker, for example, and all that sort of stuff. And then there's a third level as well, the tertiary, where a person has got already an ongoing medical problem, let's just say for diabetes, for example. We can put preventative activities in to prevent that diabetes getting any worse. So there's kind of three levels going on there. So like I say, where the hell do you start when you're a busy GP? Well, it starts with the history, and I think that's critically important. I really, really do. So the Redbook. Okay, the Redbook is a resource that has been around now for look, I can't give the exact, between 5 and 10 years. It's been continually updated. The last edition was 2009. And the Redbook encompasses guidelines, evidence-based guidelines for preventative activities within general practice. And how it's designed is along age groups. So, for example, there's a section on a younger child, for example, a middle-aged male, for example, and an elderly person. And it goes through various scenarios whereby you can actually identify a preventative activity within that. It comes with a wall chart. You can put it on your wall if you so wish. It's certainly available on the web, and for example, again, the New Zealand Cardiovascular Risk Calculator is in the Redbook. This is the Redbook here, and at the back of the Redbook it shows you a picture of how to measure risk in people. There's probably a better one available now, in my opinion, for people when you're actually gauging cardiovascular disease, for example. On the web, there's the Australian Cardiovascular Risk Calculator, which is really, really good research. I have it on my desktop all the time. I use it all the time. And basically, it puts together relative risk, all the risks into an absolute risk. So basically, if you are, let's just say you're 52, you're a smoker, and you've got a little bit of blood pressure, and your cholesterol's a little bit up, you can punch those figures into this system, and it will give you a percentage figure of your chance of a cardiovascular event in the next 5 years. So above 15% would be a higher risk, less than 5% would be a lower risk, obviously. And you can actually show patients that on screen. And it's derived, as I say, from the Redbook. You can also compare. So you can show a patient if your blood pressure drops down by this much, if you stop smoking by this much, you're going to get that much percentage back. So I think that's a really good visual tool for GPs to use. And again, that is, as I say, based on the Redbook. Now, the Redbook is being updated as we speak. We have a national standing committee within the College of GPs who look at quality care, and there's about 10 members of that committee, and they are looking at the moment of each and every one of the guidelines within the Redbook. They are measured upon the level of evidence. So level 1 evidence, for example, we know smoking, for example, stopping smoking is good for you. There's really very, very good evidence for that. If there's not such good evidence, then it goes down 1, 2, 3, 4. 4 would be basically, yes, we think it's a good kind of an idea. Now, there's lots of grey areas in there, of course, and we'll maybe talk about that in a second, but I think it's important to differentiate also between screening and case finding or diagnostic tests. So screening is looking for a disease before it presents, basically. Case finding is, you know, you're seeing someone on a day, it's opportunistic, you're sorting it out on the day. So there is a difference there. I guess the other thing that one has to say in this modern day and age is that some screening activities are associated with harm. And you may have read in the British Medical Journal just 2 weeks ago written by one of our colleagues from the University of Newcastle, Ron Monaghan, about the fact that we are creating illness. So you come and see me just with an upper respiratory infection. I tell you you've got blood pressure. You walk in as a person, you walk out as a patient. So I think there's some inherent issues there. And I think it's really critically important that we as GPs inform patients correctly. I don't think in the past we've been particularly good at telling people what blood pressure means. For an example, it's just a measurement. It's just a measurement of risk. It doesn't mean you're sick or unwell. It's a measurement of risk. So I think we have to be well aware of those things as well. So I think that, as I said, all screening tests can be associated with harm. And it makes overdiagnosis, making needless anxiety, needless appointments, needless tests, drugs, and even operations in some examples. I guess we should probably also mention too that there's a new Redbook for Aboriginal and Torres Strait Islanders.
Yep.
And that's just been released by the college about 2 months ago, and that's the book there. Again, it has charts in there, which goes by age again. So this is a rather large, complicated chart, I feel. But I think in a rural health situation, if you're an Aboriginal health worker, I think this would be very, very useful. So again, it goes by age or indeed by illness, and it tells you what you should be screening for prevention. It's a very busy slide, but I think it has a use there for you. So again, the message I think for general practice, these things are thick documents.
Yep.
And a busy GP probably doesn't have time to read through. I think it's certainly worth a flick through, have a look to see roughly what things are going on there. But my feeling all along is that if you take an adequate history, then you're going to identify most people's risks.
Can I just ask, how different are the circumstances that need to be screened for?
Well, sure. I mean, there are some new sections in the ATSI Redbook. There's talk about gambling in there, which is not talked in the RACGP Redbook for the rest of us. There's a little bit more emphasis on young people screening, especially in pregnancies and antenatal care and illicit drugs. Mental health is a big part of it. And there's also a specific part for preventive health in elderly Aboriginal and Torres Strait Islander people as well. Alongside the Red Book, the college also produced 2 years ago the Green Book. The Green Book is actually how to put these things into practice. And that's basically aimed at practices like mine here in Mandurah, who have identified a need within their patients. How do you actually do that? And it goes into quite detail of how you could do that within a practice. I suspect it's probably not appropriate to talk about that today, but it goes through plan, do, act, study cycles, PDSA cycles, etc. So again, it's a useful resource for general practice. Again, it's available on the website. Equity issues are important. Literacy issues are important if people don't understand what you're talking about, and how you change behaviour. How do you change a smoker into a non-smoker? These are perennial difficult questions for general practitioners. There are various models of changing behaviour available, and again, they're both models. The main model, I should say, is described in the Red Book, of people who are pre-contemplating change, contemplating change. Most people are aware of those things there.
A lot of those, there's a lot of specific resources too from individual organisations like Cancer Council in terms of smoking.
There are lots and lots, there's lots of stuff out there. And a very common scenario these days is for a patient to come in and say, well, I've looked at this website and we should be having this test. And I guess we should be talking about the prostate test when people always ask us about the PSA. The college position at this stage of the game is that there is no good proof that there is evidence for screening, but it does save lives. And in fact, the American Association has also backed that up in recent times. The Red Book is actively looking at it again at the moment. It is a difficult scenario for general practitioners. My personal approach, if you'd like to hear it, is if a 60-year-old man comes to see me for any associated medical issue, and he asks me, and I bring up the prostate check, I will normally talk to a patient in their 60s about the main cause of morbidity and mortality. So I'll talk to them about cardiovascular risks. 30-35% of the population have those. 30-35% of the population have cancers, as a rough guesstimate. So when somebody comes along, if it's cardiovascular, I'll talk about smoking, nutrition, activity, alcohol, physical activity, family history, etc. We've covered some of that already. As far as the cancer group of drugs are concerned, I'll talk to them about reducing cancer risk, skin cancer, lung cancer in a smoker, breast cancer in a female, pap smear, cervical cancer in a female also. Bowel cancer is good evidence that we should be screening. So all the above that I've just mentioned, there's good evidence that we should be screening for, in case finding those people as well. Prostate is a difficult one. So if you take 1,000 men at the age of 60 and offer them a PSA blood test, 900 of them approximately will test negative. So of that 900 who are negative, approximately 30 will have prostate cancer. The other 100 with a positive test, only 30 will have cancer, 60 odd will not. So it's not a great test. So you have false positives and false negatives.
So low ceiling, high floor.
Correct. So one has to discuss that with the patient. That's sometimes quite a difficult concept because they've heard their mate down the road, etc., etc. So it's quite a difficult concept. So the college position at this stage is to discuss it, give patients informed consent, and then they can decide whether or not they wish to have the test done. So a PSA is in the news, and you will hear various opinions about that, but the evidence base in the Red Book is that it should not be used as a routine screening procedure at this stage.
Sure.
The other kind of an interesting bit of, not fun, but interesting bit of information in the Red Book is there is no evidence for screening for, because people do ask about these things, annual physical blood checks. There's no real evidence that makes much difference. And that there was an article, in fact, I was reading a few weeks ago in the New York Times about exactly, because it's very much an American thing to have your annual physical, and there's really no evidence of that whatsoever. So it's an expectation over there. But there's also no evidence for screening for abdominal aortic aneurysms, doing a vaginal examination, which in my day, when I was a young doctor doing gynecology obstetrics in my younger days, we were always routinely taught to look for pelvic masses when one did pap smears, but there's actually no evidence base that doing an internal makes any difference. So it's really, we shouldn't be doing that. The other female thing that all women, of course, are incidents of ovarian cancer. And believe it or not, ovarian cancer is a very difficult diagnosis for doctors. It generally presents with very non-specific symptoms.
And quite late often.
And quite late. And generally the presenting complaint is abdominal swelling, bloatedness. So it's and lots of things can do that. So yes, there are some tests, but they're confirmatory tests, they're not screen tests. So there's a blood test and obviously an ultrasound scan. There's also no evidence for screening for coronary CT scanning, which was in vogue a few years ago. There's no evidence for exercise stress testing with the executive checks. There's no evidence that it picks up anymore. In fact, it causes more false positives than false negatives. Lung cancer is the other one people are talking about all the time. Should a smoker be having a chest x-ray every 2 years, for example? There's no evidence of that. Some evidence in the States coming out now that CT scanning may well pick up some early, but again, that's a research project. Doing a thyroid blood test, for example, there's no evidence for that either. So these are some of the negatives that actually are in the Redbook as well, which are kind of interesting for some doctors, I think, because it kind of gets them ingrained sometimes that you should be expected to do all these things.
Absolutely, all of those things are out there in the public arena as things that potentially doctors should be doing.
Correct, yeah. So I think the Redbook is a very good resource. Of course, nothing is 100%, and as I say, it's being updated these days as we speak. And we hope to relaunch the new Redbook in the GP12, which is in the Gold Coast this year in October. So there will be a brand new update of the Redbook. So it's available in paper. It's also available on the web, on the RACG website. Also, as an RACG member, you can also access a phenomenon called the sidebar. I don't know if you've heard about the sidebar. The sidebar is a college product whereby you have it on your screen, so you come and see me as a, I'm not sure how old you are, but let's just say you're a 45-year-old male. It'll actually flash on your screen, has this patient had X, Y, and Z? So once you've asked those questions, it disappears, it won't ask you again. So it's a pretty good resource. Again, it needs refining. It's not working on everyone's software, unfortunately, but I think, again, that's a way for the future for people. The other preventative reminders that do happen in general practice are, depending which software you use, for example, Best Practice or Medical Director, they do have some alerts which come up as well. So people are kind of moving in more and more in that direction. Of course, the federal government's very keen on it with the Preventative Health Task Force a couple of years ago. So I guess my message to general practitioners is we do it routinely without even thinking about it, actually.
Yep. And it starts with that history.
And it starts with that history. Absolutely. So you identify, if it's a child, for example, that comes in, a 3-year-old child and a 4-year-old, because now the government's very keen on us doing the 3- and 4-year-old checks. And if the parents haven't had them, then they actually don't get their rebate from the government. So there's good evidence now for some screening in some kids. The evidence is not strong, I have to tell you. But, you know, checking eyesight, hearing, etc., etc. My personal experience would be that mum knows best. And if there's an issue with that child, it normally presents with mum. So if there's a visual or a speech delay problem, for example, mum has usually picked it up before they come for their 3- or 4-year-old checks. It's a great opportunity, of course, to talk about immunisation. It's a great opportunity to talk about diet, about increasing childhood obesity. So there's all sorts, and you can height and weight them, make sure that they're growing along their normal percentiles and not going too high or too low. So there are some good things to do there. But the evidence base for doing that is not strong, but there is some evidence.
And our thanks to Dr. Jones for his time. Sexual health physician Dr. Jenny McCloskey took the time to speak with us about the HPV vaccine and the role it plays in preventing cervical cancers.
Jenny, welcome to the program.
Good morning, it's wonderful to be here.
I hear that we may be seeing an expansion of the HPV vaccine program to include boys. Can you just talk us through where we're up to with that vaccine program and whether or not that's true, whether we're going to see boys included in the program?
Yes, the government has agreed to roll out the program of vaccination against HPV for boys starting in 2013. So boys in Year 7 will be offered free vaccination, that's boys aged 12 to 13, and they're going to do a catch-up program, so boys aged 14 and 15 will also be vaccinated. So that's years 8 and 9 will also over the next 2 years be offered the vaccination as well. So that's just the news that we've been waiting for such a long time. We're really excited.
But is HPV associated with any actual pathology in relation to boys, or is it just to do with the overall public health?
The vaccination that's being offered for boys is the same as girls. So it covers 4 different viruses in the vaccine, so 2 that are linked to cancer and 2 virus strains that are linked to genital warts. So boys do get genital warts and we want to prevent them getting that infection. But also boys, there's an epidemic now amongst some men who are actually getting anal cancer in alarming rates. And also they're actually finding that men are at an increased risk of getting throat cancer. And so we believe the vaccine's going to reduce anal cancer, reduce warts, and also throat cancer and penile cancer. So an extraordinary outcome for the boys and really very much needed.
How will that extension then be rolled out? Will it be done through schools or...?
So the government has chosen to fund the vaccination for boys in addition to the girls that already fund. So that funds it. But it's also important to realise that for people who weren't vaccinated at school, that if they're in the age group of risk and they've missed out, then they can go to their GP and the GP can actually apply to get extra vaccination and give them the catch-up vaccine that way, or that can be done through their local councils. But the vaccines are actually licensed in boys up to the age of 25 and in women up to the age of 45. So older men and older women can in fact be vaccinated through their GP, but in that case the government's not paying for it and the individual needs to pay. It's actually 3 injections, and if they have to pay for it, it is quite expensive. So the government's being very generous, funding a vaccine that normally costs $150 per injection. 3 injections are required, so say we have 1 injection today, the next one's due in 2 months, and then the final injection is given at 6 months. And all 3 injections are thought to be required to actually produce effect. So people aren't covered from the vaccine until the final injection is actually given.
Is there a lifespan for the efficacy of the vaccine?
At the moment there's only data in women up to about 7 years, and that's shown to be very good at the moment, that the memory of the vaccines lasting for a long time. Whether in fact a booster will be required down the track, we don't know, but at the moment the data is excellent, that in the really sexually active age groups it's holding, so no booster is currently required.
If people are vaccinated then against HPV, that's obviously protective against cervical cancer, but does it eliminate the need for monitoring?
The question really is, do women have to keep having pap smears even though they've been vaccinated? And at this point in time, the answer to that is yes. We want women to keep having their pap smears every 2 years. Now, it's very likely in the future things are going to change. And it'll be driven by advances in technology and also more about the understanding of disease. But in the future, it's likely the screening interval might be extended, maybe up to every 5 years, but there has to be a national committee to examine and give guidelines. And the other thing is that it's possible in the future we may go to just testing for strains of virus and then just doing the pap smear component on those women that actually test positive. So, but at the moment there are more strains of human papillomavirus that can cause cancer than are actually in the vaccine. So it's very important that women continue with their pap smears, just in case they've got one of the unusual strains that aren't actually covered.
Is there anything else other than the presence of HPV that can result in cervical cancers?
Not as far as we understand. Basically, they've looked at lots of cervical cancers and they've found some strain of human papillomavirus in nearly 100%. The data's like 99.7%, so that's 100%. So all cervical cancer is believed to be due to human papillomavirus. And it's the same with anal cancer, that they think most anal cancers now are due to human papillomavirus as well. It's almost ubiquitous in the environment. The lifetime risk of a woman actually catching some sort of strain of human papillomavirus and getting abnormalities on her cervix is 80%. So it's extraordinarily high. And these are invisible changes. That's why we have to do the cell tests or tests for the virus to actually find the disease. So the other thing that's really involved with reducing cancers in countries like Australia and Sweden has been their pap smear recall programs. So active government-sponsored programs that really do remind people to come back and have their tests has been shown to be one of the key factors as well. But Australia is leading the world now. We're the first country in the world to be offering the vaccination to boys, and we were the first country in the world to be offering it to girls. And the other evidence from vaccination programs too has been that if you give it to school children, then your uptake is much more successful than if it's given later. But we need to give the vaccine early, so before people start sexual experimentation, and that starts quite early in quite a few communities.
Are we having an impact on the rates of cervical cancer?
It's a little bit early to evaluate the effect of the vaccination program on cervical cancer, but already, again, Australia has been the first country in the world to actually demonstrate that the rates of genital warts in women have fallen very dramatically since the vaccination has been introduced. And also there's been other data published that has shown that the rate of cell abnormalities, the pap smear abnormalities, has actually fallen since the introduction of vaccination as well. So we need time, because if you get infected with HPV, it can take anywhere from 9 to 40 years to get a cancer. So it's going to take quite some time to demonstrate that cervical cancer rates have fallen, but at the moment the precursors that lead to cancer are reducing. So very positive signs that this vaccination is really doing what it was intended to do.
What are the things that GPs can be doing or should be thinking about in relation to maximising that for their individual patients, but also in a public health perspective?
I think GPs should be asking women if they've been vaccinated, encouraging those who weren't vaccinated to be vaccinated. I think there is a lot of room to encourage women who can afford to have their own vaccines to still be vaccinated, because the truth is that even though they might have already got one sort of HPV, it's very unlikely that they will have got all the types of vaccine, or all the HPV types in the vaccine, so there's still benefit. The other thing we know about society now is there's a lot of marital breakups, and so it gives people protection for the future with future partners. And I think the other message is that human papillomavirus is sexually transmitted, but they need to think about other sexually transmitted infections as well, and we want to know that people are HIV negative. And testing for chlamydia in young girls and boys is really important. And especially in the rural areas, we know that chlamydia is really epidemic. So a urine test in girls and boys for chlamydia is really something that I would really like to see a big increased uptake in. So the message that I'd really like to get across at this stage is check to make sure that your patients have been vaccinated, check to make sure that they've had all 3 injections. For those who are still in the school age, then they'll be able to get the vaccine free through either the health department or the council. and think about chlamydia testing, just urine testing in girls and boys as well.
And our thanks to Dr. Jenny McCloskey for chatting with us. Deb Schofield is the Manager of Education Services at Diabetes WA, and she gave us an update on the current management of diabetes.
Deb, welcome to the program.
Thank you.
Now, the public health message seems to be well and truly out there of the risk of diabetes and the burden it places on our health system. It seems to be out there, but are we making a difference to the onset of diabetes? Are we preventing onset of diabetes, and are we preventing morbidity?
I think we're trying to prevent diabetes, but I think there's a lot more that needs to be done because the prevalence of diabetes is increasing. We know that 4% of the Australian population now have diabetes, and that's knocking on towards 1 million people. And we certainly have our fair share in Western Australia. More worrying is the rate of diabetes in the Aboriginal population, who are likely to have it 3 times high, a rate 3 times higher. We've got a whole range of ways that we address this and that we reach out to both health professionals and also the person with diabetes. Firstly, there's a whole range of information fact sheets that are downloadable from the website, and they're really useful for, they're quite popular. People, quite often access those, and we point them towards those on absolutely everything you want to know about diabetes or preventing diabetes. But also we've got some excellent programs that are running. We've been piloting an evidence-based quality program called DESMOND, which stands for Diabetes Education and Self-Management for Ongoing and Newly Diagnosed, hence the acronym DESMOND. It was developed in the UK, and it's outcome-based, so we know that if we run this program the way it's supposed to be run, we'll get positive health outcomes for people with type 2 diabetes.
Do people have to come to the Metro to do that?
What we would love to see is educators and practice nurses training in DESMOND. At the moment we've got pilot sites in Geraldton and also in the Albany region as well. So we've got educators trained in DESMOND there, and you do have to be trained in the DESMOND philosophies and the education behaviours to get the outcomes at the other end. So it's quite a rigorous process for the educators, but it's worth it because the people that come to these courses get a really, really good grounding in self-management of their diabetes. They live with it 24/7, and they're the ones that need to be able to manage it day to day.
Absolutely.
Yeah.
Having said that, what do you perceive the role of the GP as being in someone's ongoing management of their diabetes?
I think they're the hub and centre. They're the ones that obviously that diagnose the diabetes, that pick up those who are high risk of developing diabetes, ensure that they have appropriate testing. And then they're the ones that are going to do that initial signposting into education. And we know that people who are diagnosed with diabetes, it's essential that they have access, at least a chance to go to some sort of self-management education, whether it's one-on-one with, depending on the availability in their area, whether that's a one-to-one individual consultation with diabetes educators and dietitians, or whether it's a good group education program that's running in their area. We do find group education works so well because you get that peer interaction.
Yeah,
it's quite powerful.
Almost a contamination of information.
Yes, they learn from each other, and that's one of the underpinning philosophies of DESMOND, is people learn from each other, as well as realising that they actually know a lot already and just building on that knowledge. Yeah. There's a Commonwealth funded scheme called NDSS, which is the National Diabetes Supply Scheme, and most GPs I'm sure would know about this, and health professionals out there. But it really is important for anyone who is diagnosed with diabetes to be registered with the scheme. When they're testing their own blood glucose levels, they'll get their testing strips at a greatly reduced price. If they're on insulin, then they'll get their needles and syringes for nothing. It's really important that they connect in with that scheme. It will give them far more than the PBS will be able to supply. So it's not enough for them just to be on PBS. And even if in the more remote communities people are on Section 100, the NDSS scheme is still the better benefit to be on. So I just would encourage that anyone who is diagnosed with diabetes is put on that scheme, including women who are diagnosed with gestational diabetes. There is now a specific gestational diabetes form. We're happy for GPs to contact us here at Diabetes WA, and we'll make sure that they get the forms they need, or they can download them off from our website.
Is there anything else that Diabetes WA has been working on that might be of use to clinicians or to their patients that they could pass on?
Yes, Diabetes WA have recently partnered with St John Ambulance, who, as we know, for years produced excellent first aid kits, because what we wanted to do was have a diabetes first aid kit, so that anyone out there who's come across someone who's having a hypoglycemic incident and need treatment would be able to pick up the kit and with very simple instructions be able to help that person who's having that event. We see it having great application in workplaces, schools, sporting organisations, and the individual may well want to have a kit themselves. Perhaps they're going on an extended holiday and they just want to have something that will reassure them that they can treat themselves quickly and efficiently. We have recently developed some resources which will be really good management tools in the Aboriginal population. There's some pictorial guides that will be of great use, I think, to health professionals working with Aboriginal people. As the name suggests, the pictorial guides, they are culturally appropriate pictorial representations of managing diabetes, looking at food, looking at exercise, and looking at foot care. They are a management tool. They're not an information book just to be given out anywhere. I think their value is in actually using it with people and going through the information with people as an education tool.
So Deb, what are your key messages then in terms of picking up diabetes and helping people manage their diabetes?
That we need to be aware of the people who are at highest risk of diabetes, to go through the AusDiab risk test with people and highlight and pick up those people that are likely to be developing diabetes, get them tested, diagnosed properly, get them on the NDSS scheme, make sure that they have access to good education programs that will teach them self-management, get them testing their diabetes so that they can monitor themselves, and have regular follow-up for those people. We're on the journey with them through the whole of their life, and they're going to need different things at different stages, and just make sure that they have access to those services.
Now, if you're interested in further education and information about cancer prevention in your practice, the Cancer Council provides a GP education program. If you'd like information about the program and its educational initiatives, visit the Cancer Council at cancerwa.asn.au. And if you'd like information about cancer prevention and support services for patients available in your region or any other aspect of cancer, please visit the Cancer Council website or call the Cancer Council helpline on 13 11 20. We're back on the 4th of September with the program looking at complex comorbidities. I'm Jerry Gannon. Thanks for joining us once again.